Welcome everyone to this exciting day, Richard Blake's dissertation defense. I'm so grateful to all of you for being here and witnessing Richard in his moment of glory. Today, Richard is going to be presenting a doctoral dissertation defense entitled, Does Conscious Connected Breathwork, CCB, conducted online reduce symptoms of anxiety, a quantitative study? And so we'll have Richard start us off. And after Richard's dissertation, after Richard's presentation and dissertation, we will move on to deliberate about Richard's dissertation. And his committee members are consisting of me, Sarah, his committee chair, and then Christopher Dreyer, who's coming from the PsyD department as his second member. And then we have Jim Morningstar joining us as Richard's external member, and we're so grateful to have everyone here. So without further ado, I think I will pass the baton to you, Richard.
Okay, hello everyone, welcome. Thank you for being here today. So I'm going to move on to my first slide. I want to talk to you about a significant mental health challenge that many of us face, anxiety. It's astonishing to learn that nearly 40 million adults in the US are affected by anxiety disorders. This leads to significant losses in quality of life and a huge economic burden. A global study found that nearly 29 million years of healthy life are lost due to anxiety-related disability or premature death. Anxiety is in fact the most common mental illness in the US. So what exactly is anxiety? Anxiety disorders encompass various conditions characterized by excessive fear and worry. These include generalized anxiety disorder, panic disorder, social anxiety disorder, and more. Unfortunately, the treatments for anxiety aren't always as effective as we'd like. Pharmacological interventions are often the first treatment offered by primary care physicians, but these treatments come with significant issues. Side effects such as insomnia, diminished sexual interest, suicidal ideation, and an increase in anxiety are troubling. Moreover, severe withdrawal symptoms can make patients either stay on these medications longer than needed or avoid starting them altogether. And there's even debate among researchers about whether these medications are any more effective than a placebo. Lastly, high relapse rates after stopping medication only add to the concerns. Talk-based psychotherapy, another common treatment, also has its challenges. While CBT shows some effectiveness with small to moderate effect sizes for anxiety, only 49% of participants respond to the treatment. A relapse rate of 48% in these patients is a further concern. Access to psychotherapy is another significant issue. On the National Health Service, aka the NHS in the UK, patients can wait up to 18 weeks for their first appointment and often receive only 5 sessions. This is particularly concerning because research by Wisner has shown that it takes an average of 20 sessions for patients to achieve breakthroughs. The US behavioral health system is short of 8,000 providers, which partially explains the access issue. Despite more and more people entering therapy, mental health is getting worse rather than better. According to Dr. Thomas Insel, a psychiatrist who ran the National Institute of Mental Health from 2002 to 2015, as more people seek care, we should be seeing mental health statistics improving, not getting worse. This is not true for cancer, it's not true for heart disease, it's not true for diabetes or almost any other area of medicine. Some of the worsening statistics can be explained away by the fact that more people are comfortable seeking mental health care as it becomes less stigmatized, but not all of it can. The rest might be explained by confronting the reality that current mental health treatments are not working for enough people. We need to acknowledge this to create room for new treatments. Now, I should acknowledge my own biases and positionality in this research. Personally, I have benefited from talk therapy as it helped me to partially recover from a variety of mental health conditions, including anxiety. However, it wasn't until I discovered Conscious Connected Breathwork, or CCB, that I was able to make a full recovery. Professionally, I studied psychotherapy and counselling in the UK, leaving with a postgraduate certificate. I chose not to continue becoming a licensed psychotherapist after discovering that only a minority of people benefited from it. Instead, I've committed myself to trying to improve mental health services. I no longer see clients and have no financial vested interest in the success of CCB. And this study was personally funded. The primary objective of this study was to assess the efficacy of CCB in reducing anxiety symptoms. Specifically, we aimed to evaluate if 6 90-minute sessions of CCB could improve symptoms of mild to severe anxiety. To measure this, we compared pre-test and post-test anxiety levels using the Zung Self-Rating Anxiety Scale, also known as the ZAS. We also had several secondary objectives. We wanted to examine the adaptability of CCB in an online setting, explore the potential broader applications of breathwork therapies, and measure how much of an impact the frequency of use of a daily guided self-practice recording of CCB had on anxiety symptoms. CCB is an umbrella term that covers a specific technique from various breathwork schools, such as holotropic breathwork, breath guru, transformational breathwork, rebirthing, and therapeutic breathwork. The frustration and awareness of the limitations of conventional treatments for anxiety have led to growing interest in alternative therapies such as CCB, which is emerging as a promising, low-cost, accessible intervention. In recent years, the popularity of breathwork has surged. Google Trends shows a 3,233% increase in searches for breathwork since 2009. However, this surge in popularity has brought challenges. Many breathwork training schools have not signed up for regulation or oversight, affecting the field's credibility. Additionally, breathwork can attract people who may not be best suited to the healing profession, and the barriers to entry as a practitioner are so low that these people are not weeded out, further impacting credibility and potential harm to clients. Historically, CCB has been explained through the lens of transpersonal psychology. However, this approach may have held it back from emerging as a mainstream mental health treatment. I aim to reposition CCB as a legitimate, evidence-based secular healing technique in the same way as mindfulness meditation. To gain mainstream acceptance, we need rigorous scientific evidence to support CCB's effectiveness and safety, something that historically the field has not focused on. Given that mindfulness meditation received approval to be prescribed by doctors on the NHS in the UK, I think it's possible that CCB could also serve as a life-saving tool in health services around the world. This is especially true in light of a study conducted by Balban et al., which included the podcaster Andrew Huberman as an author and found that breathwork was superior to meditation for reducing anxiety. CCB is designed to facilitate emotional and psychological healing. Stanislav Grof developed it in the 1970s, and he recognized that while activating the unconscious was new to Western psychotherapy, it had been used for centuries in other cultures. The key components of CCB, as defined by the International Breathwork Foundation, include continuous circular or connected breathing without the usual pause between inhalation and exhalation, diaphragmatic breathing with an active inhale and a relaxed passive exhalation. The breathwork is done through a consistent breathing channel, either through the mouth or nose. The healing comes from the breath and the breather's innate healing capacity, not from a facilitator. A positive intention is integral to the process, and a full breath is encouraged. Existing studies on CCB show promising results, but with varying methodologies, confounding variables, small sample size, non-existent controls, and lack of peer review. I would describe the existing research as scatty, but improving. I really thought about the hierarchy of evidence as I wanted to do something to help CCB gain more credibility. But perhaps with this updated hierarchy of evidence, I should have just focused on getting Andrew Huberman to endorse CCB. Two studies specifically look at CCB's effects on anxiety. Brewerton et al. 2011 and Nedum-Palil 2014 both conducted studies looking at CCB's effects on anxiety in alcohol-dependent people. While both studies found statistically significant reductions in anxiety, the studies have several factors that limit the value of the conclusions. One was a clinical case study with just 4 participants. The other was a single group design of 30 participants. So both were very small sample sizes and neither had a control group. The participants in both studies were receiving several other treatments in the alcohol-dependent recovery centres. So it's not possible to say how much CCB or the other treatments contributed to the reduced anxiety symptoms. The gap in academic knowledge related to CCB and anxiety really comes down to the study designs themselves. So for our study, I wanted to be sure that the conclusions about CCB and anxiety would be robust. Another obvious gap was that no research had been conducted utilizing online CCB. A fair amount of qualitative research has been done trying to understand how CCB works, but nothing has been conclusive. Reinwein and Williams's research found that CCB helps individuals confront and process emotions they might have been avoiding or suppressing. These are the 2 most common maladaptive strategies for dealing with anxiety. Reinwein and Williams's research indicates that CCB induces a state of transient hypofrontality in the brain. This is the part of the brain that is responsible for inhibition. When it receives less blood flow, it can no longer hold on to these suppressed emotions or memories, leading to their release, processing, and thus therapeutic progress. Studies by Posse et al., Agadzian, and Perkins and Joseph using fMRIs and EEGs support this notion, finding decreases in brain activity linked to emotional release during CCB. They also found clues as to why people experience euphoria during CCB. Adyen et al. Explored how CCB affects the autonomic nervous system, suggesting that breathwork assists in regulating the HPA axis and autonomic nervous system by stimulating the vagus nerve through overbreathing. This regulation is crucial for improving emotional stability and reducing anxiety, because there is a clear link between autonomic nervous system dysregulation and the development of anxiety disorders. The largest study on CCB to date was conducted by Amidst in 2013. This study was particularly reassuring because the trial ran for 12 years and included over 11,000 participants, and no lasting adverse events were reported. However, again, this was done in an inpatient clinic, so there's so many confounding variables that the conclusions are not really worth mentioning.
Richard, I just sent you a little chat that I wanted you to, take a look at.
Okay.
I don't know if it's the headset, but just maybe.
Sure, I can bring my, okay, hopefully that's a little bit better. I brought my microphone a bit closer. Okay. There we go. Next slide. Okay. As we delve deeper into the effects of CCB, it's important to discuss the fascinating concept of non-ordinary states of consciousness. These are transient changes in a person's waking conscious experience, which can be self-induced using psychedelic substances, flotation tanks, meditation, and breathwork. They can also be experienced during regular occurrences, such as daydreaming and unusual events like near-death experiences, and they often include mystical experiences. CCB often gets compared to psychedelic trips, and for good reason. Matoni et al. Conducted a systematic review of psychedelic therapies for anxiety, and they found that substances like ayahuasca, psilocybin, and LSD consistently produced immediate and significant antidepressant and anti-anxiety effects when used in supportive settings. This review highlights the potential of altered states of consciousness to produce substantial mental health benefits. Johnson et al. Provided research showing that mystical experiences are associated with improved mental health. Bahi et al., Ehrman, and Pressman conducted studies that found that CCB can also elicit mystical experiences. Their research suggests that these experiences induced by CCB could significantly reduce anxiety symptoms. For instance, Uthaug et al. Found that CCB improved life satisfaction and stress levels to the same extent as trials done with the psychedelic 5-MeO-DMT. And that 11,000 person study by Ehrman found that 82% of people had a mystical experience at some point during the trial. Colasanti et al. Used fMRI to show that CCB creates brain changes similar to those seen with psychedelic use. Their study involved 19 participants performing a type of CCB called high ventilation breathwork. They found that this CCB technique changes cerebral hemodynamics, leading to progressive disruption of insular cingulate interactions, ultimately comprising self-central representation. This suggests that the profound changes in thought, emotions, and self-experience resembling altered states of consciousness during CCB may have a valuable mechanism for therapeutic healing. A similar mechanism of action is found in research showing substances like MDMA and psilocybin downregulate the brain's default mode network, the DMN. The DMN is responsible for giving us our sense of self. When the DMN is downregulated, people can adjust dysfunctional beliefs about themselves that may contribute to their anxiety. Some breath workers have hypothesized that CCB is also downregulating the DMN, like psychedelics do. While this is all very well, no research has been done that shows that a CCB-induced mystical experience leads to mental health improvements, and hence this is an obvious area for future research. Understanding trauma and its impact on anxiety is crucial for effective treatment. Trauma can have a profound effect on mental health, and unprocessed trauma is often at the root of many anxiety disorders. CCB offers a promising approach to addressing this issue. Lau Kaun et al. Found that if a patient is diagnosed with partial rather than full post-traumatic stress disorder or PTSD, their symptoms are often subsumed within other disorders such as anxiety. And this highlights the interconnected nature of trauma and anxiety, reinforcing the importance of effective trauma processing in reducing anxiety symptoms. And the concept of trauma has entered mainstream pop psychology, and the word seems to have lost all meaning. However, there is a strict definition, and it comes from the Substance Abuse and Mental Health Administration Center. This states that trauma must have three key aspects: an event, an experience, and effects. Further, trauma is a specific event that leads to a change in the stress response system. This is, of course, shock trauma, and different definitions exist for complex and even intergenerational trauma. However, this is beyond the scope of this study. Drawing parallels with established therapeutic techniques such as somatic experiencing and eye movement desensitization and reprocessing, aka EMDR, CCB may offer a similar way to process trauma as these other well-researched modalities. EMDR has substantial evidence supporting its effectiveness for anxiety, demonstrating that processing trauma-related procedural memories into episodic memories can significantly reduce anxiety symptoms. Similarly, CCB might help individuals enter a state that facilitates this kind of memory processing. There is just one study that specifically looks at CCB and PTSD. DeWitt et al. Conducted this clinical case study. The participant experienced complete remission of PTSD symptoms and a marked reduction in anxiety and depression after 8 sessions of CCB. However, given this was a sample size of n equals 1, its generalizability is very limited. Understanding the bodily effects of CCB is crucial to appreciating the multitude of therapeutic benefits. Sanchez-Quijano et al. Compared holotropic breathwork with a control group to assess changes in resting heart rate as a marker of anxiety. Despite heart rate being influenced by various factors like hydration, immunity, and sleep, the study found that holotropic breathwork had a medium effect size on reducing heart rate compared to the control. Collinge and Yarnold, 2001, investigated evocative breath therapy's impact on immune function rather than psychological symptoms. In this pilot study with 45 participants, they measured salivary immunoglobulin levels. They observed a 46.3% increase in salivary immunoglobulin across participants. Given how research is starting to build up that anxiety can be caused by inflammation and low salivary immunoglobulin levels, this is a very interesting finding. However, the study's small sample size and lack of long-term follow-up limit its conclusions. To explore the effectiveness of CCB, I designed a true experimental study with pre-test and post-test measures. The independent variables were CCB and time, and the dependent variable was anxiety symptoms. We had a third independent variable, adherence to a daily CCB self-practice. Participants were adults with varying levels of anxiety, recruited online from a wide range of countries across the world using the flyer shown here. Each session began with an introduction, followed by answering participants' questions. Then participants engaged in 40 minutes of CCB in the style developed by Alan Dolan of Breath Guru, followed by a 10-minute rest period with grounding visualizations. These sessions concluded with 10 to 15 minutes for participants to share their experiences and ask questions. Our study had an N value of 108 participants. The mean pre-treatment ZAS score for the treatment group was 43.87 out of a possible 80, indicating moderate anxiety levels. The cutoff for a clinical diagnosis on the ZAS is a score of 35 or above. After the 6-week intervention, their mean post-treatment score dropped to 33.31. This 10.56 point reduction is highly significant, showing that participants moved from moderate anxiety levels to normal levels of anxiety on average. In contrast, the control group had a pre-test mean score of 43.00 and a post-test mean score of 41.11, showing a negligible reduction of only 1.89 points. This small change underscores the effectiveness of CCB compared to treatment as usual. To statistically analyze these changes, I conducted t-tests. The t-test was appropriate because it tests for differences between the means of two groups, assuming equal variances, which are verified through sphericity assumptions. The p-value for the difference in anxiety reductions between the treatment and control group was less than 0.001. This means there is less than a 0.1% probability that the observed difference occurred by chance. To understand the magnitude of the treatment effect, I calculated the effect size using Cohen's d. Effect size is a crucial statistic in research that helps us understand the practical significance of our findings. While statistical significance tells us whether an effect exists, effect size tells us how large that effect is. Cohen's d is a measure of effect size that expresses the difference between two means in terms of standard deviation units. In my study, Cohen's d was 1.44 for the treatment group. An effect size of 0.2 is considered small, 0.5 is medium, and 0.8 or above is large. Thus, an effect size of 1.44 is exceptionally large. This large effect size suggests that CCB had a profound impact on participants' anxiety levels, much more than would be expected from chance alone. I made sure that the dependent variables were normally distributed. I also used a repeated measures ANOVA, or analysis of variance, to compare anxiety levels at different times within each group and between the two groups. Repeated measures ANOVA seem suitable because it counts for the within-subject correlation, reducing error variance, and increasing statistical power compared to separate t-tests for each time point. The ANOVA results further confirmed that the reductions in anxiety observed in the CCB group were statistically significant compared to the control group, providing robust evidence of CCB's effectiveness. In addition to the quantitative data, I gathered qualitative feedback from some participants in an exit survey and some follow-up emails. Many reported feeling more relaxed, emotionally balanced, and better able to handle stress after the CCB. The combination of significant statistical findings, large effect sizes, and positive qualitative feedback paints a compelling picture of CCB as an effective therapeutic intervention for anxiety, paving the way for its integration into mainstream mental health practices. Skewness and kurtosis measures provide insights into the distribution of our anxiety scores and help us understand the variability in our sample and what it means for breathwork. Skewness measures the asymmetry of the data distribution. Both values show positive skewness, indicating a distribution slightly skewed to the right, with a longer tail on the right side. This suggests that while most participants had lower anxiety scores when they came in, there were some outliers with higher anxiety levels. This would make sense as we excluded people who had recently started therapy or medication, so we were not expecting people with extreme levels of anxiety. Further, if we wanted to attract participants with more extreme mental health conditions, we would have needed a higher level of clearance from the CIAS Ethics Committee, and we did not have the resources to meet that standard. Another reason for focusing on people with less than extreme levels of anxiety was that I expected CCB would be an excellent starting point for people seeking out mental health support. An example of how this might work in a medical setting is as follows. A patient goes in to see their primary care physician with symptoms of anxiety. If they score in the mild to moderate range, they are prescribed CCB. If they score in the severe to extreme range, they are referred to a psychotherapist and pharmacological treatments are discussed. However, saying that CCB just works for mild levels of anxiety is probably doing a disservice to its potential. More research is needed to assess how CCB works with severe and extreme anxiety levels, as I expect it's useful for this too. As it takes less time to train a CCB facilitator than a psychotherapist, more facilitators could be created to lessen the enormous burden on psychotherapists and free them up to deal with the most severe cases of mental illness. My wife, Natalia, is currently studying for her MA in psychotherapy, and it is an incredibly time-consuming, difficult, and expensive process. While it is great that there are so many barriers to entry to ensure psychotherapists are of the highest quality and integrity, perhaps there is room for another type of qualification that requires less time, expense, and academic ability for people who want to work with milder cases of mental illness. Now, I'm not condoning the weekend teacher training courses we see out there on the internet. I am thinking that trainings in line with the 2 years recommended by Jim Morningstar and the Global Practitioners Breathwork Alliance. Not only would this create greater access for people suffering from mental illness, but it would also enable greater access to people who are not able to afford the immense time and expense of becoming a licensed therapist. Okay, back to kurtosis. So kurtosis measures the tailedness of the distribution. These positive values indicate a distribution with slightly heavier tails than a normal distribution. This means there were more high and low anxiety scores than would be expected in a perfectly normal distribution. This variability is important to consider when interpreting the overall effectiveness of CCB. It confirms some anecdotal evidence that CCB has extremely potent effects on some people and not so much on others. CCB, like all therapeutic interventions, may not be universally effective for all individuals. The assumption that a single therapeutic modality can meet the diverse needs of the wide spectrum of anxiety disorders overlooks the nuanced and complex nature of mental health treatment. One of the most surprising findings from our study was that the frequency of self-practice did not significantly correlate with greater reductions in anxiety symptoms. I conducted a general linear model analysis to assess the impact of self-practice on outcomes, hypothesizing that more frequent practice would lead to greater reductions in ZAS scores. Participants were asked to report the average number of times per week they used the guided self-practice in their exit survey. However, the mean post-breath reductions in ZAS scores was not statistically significant. This finding contrasts with previous research conducted by Gaum, suggesting that the frequency of intervention enhanced outcomes. It may indicate that the intensity or quality of CCB sessions holds more therapeutic value than the sheer number of practices. It also suggests that the presence of a live facilitator or witness is critical to therapeutic progress. Without this support, participants might struggle to maintain the complex technique or give up when challenge arises. The lack of impact from guided self-practice might also be due to the short duration of the practice. One participant wrote in private correspondence, "I don't find the breath work as powerful when I do it alone. I've noticed that I respond very well with connection. The words of encouragement and guidance from the facilitator while in the group really helps me connect." Moreover, it is possible that the live workshops created a type of saturation effect, in that the maximum amount of benefit was squeezed from the live sessions so that no more benefits to anxiety symptoms could have been received from the self-practice. I expect many breathwork practitioners will contest these findings, given the wide range of recorded breathwork platforms and apps out there that are making money from this kind of practice. There is much greater potential to make a profit and scale recorded breathwork than doing live sessions, but this incentive should not interfere with interpreting these results. Saying that, I must again acknowledge that this is just one study. So one way of testing these findings would be to create a study that directly compared groups undertaking live online breathwork or recorded breathwork. Our findings support the three most similar studies done by Sanchez-Quijano et al., Nedum-Pelil, and Brewerton, which also showed that CCB reduced anxiety symptoms. I'll now talk about my findings in relation to the literature review. Firstly, let's delve into the mechanism of action behind CCB. As mentioned in the literature review, CCB can help people regulate their emotions. Of course, this is reflected in the substantial average change in ZAS scores, but it is also supported by some of the qualitative feedback we received. For example, one participant wrote, "Breathwork may have given me some strength to deal with certain events in my past, almost that I can be strong and let them go." Another participant wrote they feel mentally stronger after the CCB program. A third participant wrote, "I feel more able to handle my anxiety and more ease in accepting things." Psychologically, CCB helps individuals develop healthier ways to manage their emotions, aka utilizing adaptive emotion regulation strategies. It also allows them to confront and process emotions they might have been avoiding or suppressing. Our findings support this notion and suggest that CCB enables individuals to face these emotions directly, facilitating therapeutic progress. For example, one participant shared that the reason for their improved anxiety was that they had cried more in the last few weeks than they had in their entire adult life. Another participant wrote, "I noticed myself being able to express my feelings in an easier way, and I feel less anxious." A third participant wrote that they had a reduced anxiety level despite the very increased connection with suppressed grief. Trauma healing was another mechanism of action hypothesized to be a part of CCB. While our statistics cannot identify trauma resolution's role in the program, some of the qualitative feedback gives us clues. In private correspondence, a participant shared that they felt they were letting go of early life pre-verbal trauma. Another participant wrote that, "After Sunday's session, for the first time in 2 years, I felt chilled, at peace, and calm. It's given me the sense that I can emerge from that from that traumatic experience stronger and more intact." While neither of these participants have diagnoses of PTSD that I'm aware of, I think it's worth noting that these participants mentioned the theme. I feel like this is another thread that this research has pulled at, and I'm hoping future researchers can delve more deeply into this. I mentioned studies by Bahi et al., Ayerman, Pressman, and Colasanti et al. That showed CCB can induce mystical experiences, and several participants shared stories of their own mystical experiences, including encounters with deceased family members, feelings of oneness, and increased connection to a higher power. There are at least 3 studies that show that psilocybin-induced mystical experiences lead to lasting improvements in mental health. And it is possible that to suggest that psychedelic substances, CCB, and any spiritual technology that induces a mystical experience would lead to improved mental health outcomes, but further research should be done to test whether CCB specifically enables this. There are potentially many more mechanisms of action behind CCB not discussed here, such as the healing effects of music, social contagion, lymphatic drainage, increased BDNF, brainwave modulation, and more. While our study provides promising evidence for CCB's efficacy, several limitations and threats to validity must be acknowledged. First, despite this being the largest randomized controlled trial ever done on CCB, our sample size was still relatively small, limiting our findings' generalizability. Conducting the study online introduced variables that wouldn't be present in an in-person setting, such as internet connectivity issues and the participant's home environment. Think children jumping on beds and pets licking faces. Additionally, our study focused on short-term effects without a longitudinal follow-up to assess the durability of CCB's effects. To address some threats to validity, I used a random assignment to mitigate potential biases, but there will still be variables affecting the results, such as self-selection bias. Furthermore, while the ZAS questionnaire has a high Cronbach's alpha of 0.82, indicating it reliably measures what it sets out to measure, it might not capture all dimensions of anxiety or subtle changes over time. There may be issues such as the Hawthorne effect and experimenter bias that further cloud the results. Our virtual setting minimized peer influence, though positive social interactions during sessions were seen as beneficial for reducing anxiety, according to some of the qualitative feedback. I also maintained a 6-week gap between pre and post tests to mitigate the likelihood of participants' responses being influenced by their previous testing experience, memory, and immediate effects. And to reduce facilitator bias, my wife, Natalia, who is also a certified breath worker, led one workshop for each cohort while I assisted her. For all other workshops, Natalia was present as an assistant facilitator to ensure smooth running of the workshops and the safety of participants. While our findings are promising, several factors must be considered when evaluating the generalizability and ethical implications of our research. Our sample primarily consisted of participants from the UK and the US, which limits the generalizability of our findings to other populations. We had many strict exclusion criteria. All participants needed to be English speaking, at least 18 years old, and score between 35 and 74 on the ZAS. We excluded people with any of the following: anyone with a suspected history of self-harm or was actively suicidal, anyone who had started treatment for mental illness within the last year, anyone already familiar with CCB as defined by participation in more than 5 previous CCB sessions, anyone with angina, a history of heart attacks, high blood pressure, glaucoma, retinal detachment, osteoporosis, recent surgery, past or current diagnosis of bipolar, borderline personality disorder, schizophrenia, history of panic attacks, psychosis, seizure disorder, or family history of aneurysm. And one striking fact about our sample is that it contained more people with doctoral level degrees than those who left education after high school. And as is common in psychological research, only 30% of participants were male. Adverse reactions. So nearly all participants reported positive outcomes, but we did observe some adverse reactions. These reactions are important to discuss as they highlight the need for careful consideration when implementing CCB, especially for individuals with high sensitivity to emotional or psychological changes. It also highlights the need for rigorous training for practitioners as well as oversight of the industry. Tetany. The most common adverse reaction was tetany, a short-term cramping of the hands and mouth caused by hyperventilation. All participants who experienced this saw the symptoms resolve when their breath technique was corrected or they returned to normal breathing. Flooding. We had 3 more serious incidents involving emotional flooding, which is where participants feel overwhelmed by their internal experiences. 2 participants were regulated and able to continue with the sessions after receiving individual support from Natalia in breakout rooms. But a 3rd participant, who also needed support regulating in a breakout room, chose to leave the study and seek in-person CCB sessions. 1 participant reported increased anxiety outside of the workshops and chose to leave the study after 5 sessions. Follow-up indicated that their increased anxiety level was transient and that their anxiety had been reduced to levels below even what they entered the study with. 2 participants did score higher in their post-breath ZAS scores, but this was only an increase of 2% and 5%, which could merely be attributed to measurement error. Depersonalization. So another participant experienced depersonalization symptoms, feeling as if they were in a dream. This sounds like the depersonalization that can sometimes happen when people with childhood trauma use psychedelics, as according to Mattoni et al. It is also reminiscent of the work by Miller and Nielsen, who found that CCB can increase measures of paranoid ideation. Now, this participant was referred to their primary care physician and is on a waiting list to see a therapist. While she is waiting, we remain in contact. The fact that this person finished their program last December and is still waiting for an appointment highlights the need for more mental health practitioners in the UK. These adverse reactions occurred in 5% of participants, so 4 out of the 78 people who attended at least 1 session, and only 1 out of the 78 participants experienced any lasting negative effect. Crawford et al. Found that 5.2% of patients receiving any psychological intervention, including talk therapy, were left with lasting negative effects. Our study had just 1.3% of participants experiencing a lasting negative effect. Without trying to minimize or dismiss the potential harms of this technique, I think it's important to zoom out and compare CCB with other treatments. I appreciate the quote by Dr. Siddhartha Mukherjee, who says there are 2 kinds of treatments, those with side effects and those that don't work. When the Federal Drug Agency, or FDA, looks at adverse reactions for approving new treatments, it balances the potency of the treatment with the nature of the adverse reactions. Treatments with more potency are given more tolerance by the FDA than those with less powerful effects. Given that we have demonstrated CCB to have a large effect size, a large degree of tolerance might be expected for side effects. Furthermore, as mentioned previously, increased anxiety during the first 2 weeks is an accepted side effect of some pharmacological treatments for anxiety. Instead of discarding CCB as dangerous, as some people have done, we should be looking to discover how to ensure the safety of vulnerable participants while maximizing the healing benefits for those who want to benefit from this kind of treatment. This can be done by increasing regulation and training standards and conducting further research. If I could have done something differently, it would have been to have a mandatory check-in with every participant at least once during the course of their program. While we made ourselves available for people to reach out, we know that there were people who wanted support, but for reasons unknown to us, did not ask for it. I've mentioned several areas for future research already, but I will add to those now. Firstly, larger and more diverse sample sizes are needed to validate our findings and enhance their generalizability. Including participants from various cultural backgrounds in different regions would provide a more comprehensive understanding of CCB's effectiveness. Another important direction for future research is exploring the specific mechanisms through which CCB exerts its effects. More research into adverse reactions is also vital. Identifying conditions and personalities that may be more prone to adverse reactions would help mitigate the damage. Having Natalia as the assistant facilitator, along with the breakout room feature in Zoom, was vital in ensuring the safety of our participants while allowing me to continue to support the group. I would caution anyone against conducting group online CCB without at least one assistant facilitator. And the maximum ratio of facilitators to participants that we had was 1 to 13 or 2 to 26. Future research could endeavour to establish what a safe ratio should be, whilst also balancing the need to make workshops financially viable for the teachers and participants. Additionally, measuring whether CCB affects a person's functional breathing and CO2 tolerance would be interesting. And lastly, examining the potential benefits of CCB for other mental health conditions such as depression and PTSD would expand our understanding of its therapeutic potential. Our study demonstrated that CCB significantly reduces anxiety symptoms with a large effect size. This supports the potential of CCB as an effective therapeutic intervention for anxiety, particularly in an online setting. However, while the findings are compelling, it is crucial to acknowledge the limitations of this research. The study's scope primarily focused on short-term impacts without a longitudinal follow-up, leaves unanswered questions regarding the durability of CCB's effects on anxiety. Moreover, the generalizability of these results may be limited by the study's sample size and demographic homogeneity. This dissertation marks a significant step forward in legitimizing alternative approaches to mental health treatment, particularly for those seeking non-pharmacological options to manage anxiety. The evidence presented herein strongly supports the further investigation and integration of CCB into mental health practices, advocating for a more inclusive, holistic approach to mental health care that embraces the diversity of human experience in the broad spectrum of healing modalities available. As we continue to navigate the complexities of mental health challenges in the modern world, our therapeutic strategies must evolve to meet the diverse needs of those we aim to serve, encouraging a future where access to effective treatment is not just a privilege, but a universal right. And I just want to take the time to express my gratitude to my dissertation committee members for their guidance, support, and everything throughout this research. Their expertise and insights were invaluable in shaping this study. I'm also deeply grateful to all the participants who took part in this study. Your time, trust, and willingness to share your experiences were essential to the success of this research. Thanks go to my family, my colleagues, my dissertation coach for their unwavering support and encouragement. Thank you to all my breathwork teachers, and in particular, Alan Dolan, who really introduced me to this life-changing practice. And the biggest thanks of all go to my wife, Natalia, for supporting me when this all felt too big and for assisting and leading the workshops themselves. Thank you all for your attention and interest in my presentation.
Yay, thank you so much, Richard. Wonderful work. We're so grateful for that comprehensive and really, really beautifully facilitated conversation and presentation. I want to open up actually what I'm going to do is I'm going to open up comments from the committee members at this point. And what we'll do here together is we'll have a few comments. We'll hear from Jim, we'll hear from Christopher and myself. We'll ask some questions, and then the committee will go into a breakout room, and you all will have a chance to ask some questions. So I thought that we could begin with Jim Morningstar. Just opening up the floor to you, Jim, to make any comments, to ask any questions. And if you want to briefly introduce yourself before you begin, we'd love to hear a little bit about you.
Well, thank you so much, Sarah. And particularly, thank you, Richard, because what you've done, in effect, is affirm what I have lived for since the 1970s, and that is doing breathwork with people, witnessing the results, and now to confirm that with research is the cherry on top of the sundae. And particularly to confirm results with online work, which of course was seen as a stepchild to real breath work until COVID came along. And then we all had to do that. And we all had to see what its limits were, and what our fears were about it, and what its effectiveness really can be. And so for me, breath work is about coaching people to modulate their breath in a way that they can take over and regulate themselves more and more throughout their life. It's not about looking for traumas. It's not about looking for bad things in one's life. It's about empowering them to get back to the core goodness and self-health that they can monitor themselves. They need coaching in this, and they need coaches with training in this. I think part of what has kept the medical field at an arm's length from breath work is the radical nature of our going into the emotional trauma, but also because it becomes confused with hyperventilation. And this is one thing that I'm wanting to support you in the most, is there's a couple of studies that you cite and comments that are made about breath work being hyperventilation, which it is not. As a matter of fact, we are coaching people not to hyperventilate. During sessions, people occasionally will hyperventilate there, but it's understanding what hyperventilation is, which is a tightness in the breathing, which causes overbreathing, CO2 to be released. And when CO2 is released from the system, the mechanism in the brain that calls for more breathing gets activated. And when people continue to breathe more while they're blowing off CO2, they get a negative feedback cycle that goes on. And this leads to panic, because we can go without food and water for days, but how long can we go without breath? And so it induces an immense breath hunger, and you can either go to the emergency ward and they'll give you medications to calm down, or they'll give you a paper bag. A paper bag, talk about being cost effective. What a paper bag does is it induces you to start inhaling some of the CO2 that you've been blowing off because you're too tense in your breathing. So I want to make sure that in your presentation, in your dissertation, it is very clear that breathwork is not hyperventilation. I call it superventilation, or as one of your studies called it, high ventilation. And so what we're training the body to do is to process more energy safely. And you do that by relaxing on the exhale. And I was metaphorically holding my breath while reading your dissertation. It's like, when you got to the point of citing what breathwork is by the International Breathwork Foundation, point number, whatever, 5 or 6, was it's a relaxed exhale. Ah, there, that's the key to this whole breathwork business. And then you had the wisdom to include a link at the end of your dissertation to you actually demonstrating how to breathe and emphasizing, as you did, the relaxation of the exhalation, which is all important. Now, this is what needs to be conveyed to the medical profession. We are not condoning hyperventilation. We are training people how not to hyperventilate, but to increase their capacity, their heart rate variability, their amplitude of breathing safely. And safety is another big concern with this. How, to answer one of your questions, what's the ratio that we over the 50 years I've been doing this, we find one assistant. They don't have to be a trainer, but they have to have some coaching and help other people. One assistant to every 4 or 5 participants when doing live breath work. How do we do this online? Well, here's another way, just an alternative. What you did was brilliant with Natalia having a breakout room that people can go to. You can have a breakout room in which a number of people are breathing together. Of course, the difficulty with that is you can't talk to all breakout rooms at the same time, of course. But you can give instructions to everyone, and then you can have individual assistants or facilitators in breakout rooms. Or what we've also done is we give instructions to everyone. As far as music goes, they maybe have to send a clip or something like that, because again, once they're in a breakout room, they can't hear you. But we put everyone online in a breakout room. And then we take the assistants and we assign one assistant to every 4 or 5, depending on numbers, breakout rooms. And they periodically go in and check with each person individually. This is covering the waterfront in terms of no one going unmonitored during breath work. So that's just an alternative. It's in no way detracts from your study. All I'm doing is underlining, yes, let's keep this moving forward, and let's let people know this can be done safely, and we're not condone. It's not about hyperventilating, which, again, you cited, there can be some benefits to hyperventilating. Well, there can be some benefits to skydiving and all that, but no, we are coaching people to self-regulate in monitoring their breath, to do it safely and effectively. And long-term, in my work over the years, has been, people have learned it. And absolutely, once they get to that point where they can do it, everyone says it's much better when you have a facilitator, as you said. Everyone says that, and it is. It is good. It's like you take the critical mind and you give it to someone else, and now you can just breathe. The mystical experience, faster than normal breathing, takes us into the right brain. There are those limits. And the default mode network, which is in the center of the brain, actually research has been done on long-term meditators who focus on their breath over years. Autopsies have been done. The default mode mechanism is reduced in their brain. So this focusing on the breath, giving yourself a positive thing to focus on is what takes us out of the worry center. So, okay, I could prattle on here with all sorts of, but those are the 2 main things that I wanted to underline, because I really want this to get published, and I want it to be out there and to be seen, and I'll support you in every way in that process.
Thank you, Jim. Yeah, if I could just respond, yeah, I think decoupling hyperventilation and voluntary overbreathing is important, because I guess some people will say, well, it is hyperventilation because you are overbreathing, but then other medical people will be like, well, no, hyperventilation is a specific pathology, a specific problem. So I guess it's more a matter of making that clear, and I will make that clear in my dissertation. And then with the ratio of assistance to clients, I guess, when I've had conversations with people being like, you need to have more facilitators, more assistants, and they'll be like, yeah, but I can't afford that. And then it becomes about paying people, and then I have to raise the prices, and then people who can't get access to psychotherapy because it's too expensive can't get access to conscious connected breathwork because they have to pay for so many facilitators. So that's why I think doing some research to assess what is the safe ratio, using some economics, working out what's the price elasticity of demand, what's the breaking point for making breathwork too expensive and inaccessible, and then also what's the breaking point for being like, okay, well, this group is under supported and dangerous.
So just to talk about the economics of it, the fact is when I do trainings or group breath work, people who are assisting me are in process of becoming breath workers, fully trained and certified, but they're absolutely qualified to support people in breath work. They are paying me to be an assistant. So it's not like, oh, I've got to hire a whole bunch of more people to keep this thing safe. I've got to monitor that the assistants are qualified enough and are actually learning and giving value to people. So little tidbit there.
Thank you.
Great. Thank you so much, Jim. It's really valuable having your expertise on this committee. I think I'll pass it over to Christopher Dreyer to see what comments or questions you might have.
Thank you, Sarah. Yes, my name is Christopher Dreyer. I'm associate professor in clinical psychology. I got to know Richard when he was a student in my quantitative research course, and it's been a privilege to work with you then and now, Richard. Thank you very much for the very clear and knowledgeable defense of your dissertation. You can probably have anticipated my question, which is, would you speak a bit about the decisions that you made in your research design in terms of the randomization, the use of two groups, the use of a waitlist control, a pre-post measure of anxiety, and what the benefits and limitations are of those decisions?
Yeah, I think firstly, I I had to reach out to Christopher and the clinical psychology department because the East-West psychology department didn't have an expert in quantitative statistics. So I was very lucky that Christopher took me in his department. But that kind of underscores that statistics was an area that I'm least familiar with. So that's why I was made sure to have Christopher on my committee so he could give me that kind of guidance. And yeah, there were a few things that sort of made me sort of limited my choices in that I'm not a statistician. I was only going to be able to perform basic statistical measures, so I didn't want to do anything overly complex. Hence why I just had just the ZAS. Other people would say, why don't you also test depression? Why don't you also test other things, profile of mood states or things like that? And I took the advice that, just get your PhD done and then you can do more research after, once you're a better researcher. Initially, I was just going to do a single group design because I was like, oh, I don't know how to do this. I don't know how to get a control group. I don't know how to get a weight group. I was playing very small. And then Professor Dry was like, why don't you do a placebo? Just do a wait list and you can do a randomized crossover. So I was really grateful for that advice because I was just, floundering. I was going to just do another single group and it would have probably, just vanished into all the ether with all the other CCB breathwork studies that haven't been as robust. And one real concern I had was attrition, because that study by DeWitt et al., they had a study with 30 participants and it went down to 1 at the end for various reasons. They didn't say why, but I knew that attrition was going to be a big problem. And I wanted to get statistical significance. So that was why I wanted to make things really simple, because I was worried that I wouldn't have enough people making it through to the end. So I didn't ask a lot of people. I said, I'm giving everyone a $20 Amazon voucher if they finish, and all they have to do is one questionnaire at the start, one questionnaire at the end. So yeah, attrition was one of my main fears, and maybe I should have been a little bit more bold. Maybe I should have trusted that breathwork would have been supremely popular and maybe asked a little bit more of my participants. And yeah, the reason to do pre-test, post-test measures was just because it's really simple, because I wanted to keep it simple for not just me, but also for people outside of this research who are just, who don't really understand statistics, and they can just look at this study and go, well, wow, the people who did breath work had their anxiety go from moderate anxiety down to normal levels, whereas the control group didn't have any changes. So in terms of robustness and impact, I thought making things simple may actually play in my favor.
Terrific. Thank you, Richard.
Great. Wonderful. Thank you, Dr. Dreyer. We're just also so grateful to have your expertise in quantitative research in this as part of this dissertation committee. Richard, so I just want to really appreciate your comprehensive exploration of conscious connected breathwork that you completed really in record time, but you did so really responsibly. I think that what you've done is a really groundbreaking and valuable contribution of kind of studying breathwork in a way that would make it more accessible. I really feel that kind of the sort of social responsibility in creating a study to see, can these larger groups, these online groups that really make breathwork more accessible, can they be successful? And I'm so glad, as you mentioned, that you always was rooting for you to have a control group, that you decided to, add in that extra layer of complexity to make your research just so much more robust. I'm so glad that you did that. And I think that really speaks to the kind of care and attention that you put to this work, as well as the attention you put into tending to the safety and the well-being of the group and of the individuals in the group. I just saw how much thought went into that. And I just think that really is a testament to the strength of the study, as well as your really careful exploration of and inclusion of the kind of adverse effects. I think that really actually strengthens this research and is also, really speaks to your integrity. So I really appreciate that exploration as well. Okay, and a few points that I want to just sort of check in with you about and ask you about. And this first question is more of a zoning out, a kind of meta question. And I'm curious about your comment that as you notice the overall increase in anxiety in our world, you were sort of attributing that to perhaps ineffective therapeutic modalities, both pharmacological as well as therapeutic. I'm wondering if that's a totally comprehensive explanation of the situation, or is the increase in anxiety in our world due to systemic factors, complexifying social conditions? And if that is the case, is there really any silver bullet that can address anxiety that does not address these systemic challenges? I think this is something I talked to you about, as you were doing your research. I'm thinking about psychedelic research, both the potential and the limitations, right? Are we looking for that next silver bullet when in fact the issue is not so much with finding the right therapeutic modality, but about addressing some of these societal and systemic challenges? So I'm just curious, your take on that, your thoughts on that.
Yeah, certainly. I guess I did write a fair bit more about it in the actual dissertation, but for the presentation, for the sake of brevity, I didn't go into it. But certainly, yeah, anxiety levels are increasing due to so many issues, social issues, environmental issues, pandemics, social media, our diets, raising inflammation. You could go on and on and on. So obviously, I'm not saying that anxiety levels have remained the same for everyone, and the reason that they're getting worse is just because the treatments aren't good. Obviously, they're going up, but what my point is, they're going up faster than our current treatments can handle. Hence, we need more treatments to deal with that rise. And my point was only 49% of people respond to CBT. I know that's only one form of psychotherapy, but that's a minority of people. Hence, in the UK, the CBT is the only thing you'll get on the NHS. So that's why I only say that there. It's like it's CBT or it's psychopharmacology. So that's why I'm really saying, like, well, what can we have some other options? Meditation actually within the last year has been able to be prescribed. You can use an app now in the UK, but also, wouldn't it be nice to have other options like maybe psychedelics? They seem quite close in some places. Maybe exercise could be prescribed. Maybe conscious connected breathwork could be prescribed. And I'm not saying that. I guess we've had these conversations where I get quite passionate and maybe quite binary, and that's part of my my Enneagram type 1. I see things in black and white, and like, psychotherapy doesn't work for anyone, or it works for everyone. And of course, it works for some people and it doesn't work for others. And the same with breathwork. That was the point about the skewness and the kurtosis specifically, and that it doesn't work supremely effectively for everyone. And then, I did also mention like the idea that one therapeutic modality is going to be effective for everyone really misunderstands the complexity of the human experience. So, hopefully that explains things a bit better.
Yeah, great. Thank you, Richard. I just wanted to hear it in your own words. I think it sounds like you're saying that, breathwork isn't necessarily being marketed, or you're not presenting it as a silver bullet, but it just, and a desire to give sort of access this type of treatment and the healing of anxiety from different angles, like to expand the options that are available. That's beautiful. Great. Another question that I have, I'm curious about, and I think you did mention this, and I think there's a bit about this in your dissertation. Given the short-term nature of the study, to what extent do you imagine that, as in psychedelic therapy, that integration is a vital component of CCB, right? To what extent do you imagine, or have other studies shown, that the effects would fade over time if the practice was not renewed or integrated in some way?
Yeah, integration is another hot topic in the world of psychedelics and breath work. And I know there is research coming out now after the psilocybin trials that showed remission of treatment-resistant depression, that a lot of those people's depression came back after a year, and those people now can't get access to the psychedelic treatments because it's still illegal. The only way they can get it is going into another trial, which is quite sad for those people. And if we're going to say that CCB is just like psychedelics, then maybe we have to say that it's just like psychedelics in that the benefits or effects don't last forever. So certainly long-term follow-up is going to be useful. There is a study by Puente, 2014, I think he did a study with like long-term, and he actually found something quite interesting. I mentioned it in the paper, that people had greater benefits at 6 months than they did at 1 month after their study, but his was quite a small sample size, and I think there were other treatments as well as things like that. So definitely someone should do some research. Maybe it'll be me on how people do after 1 year, and sort of how long the benefits last. Is it 9 months? Is it 1 month? And how frequently should people go back for another program, CCB?
Wonderful. Yeah, that would be, I was going to ask, because you think you might do that kind of follow-up research. Do you feel that conscious connected breathwork would be something that would go well in conjunction with talk therapy?
Yeah, I think it would go. I mean, I think all things go in conjunction well. Psychedelics go well with CCB. Psychedelics go well with talk therapy. Talk therapy goes with all these things. And I think unearthing that material. We talked about transient hypofrontality. People's emotional baggage coming up from the unconscious. Maybe the best way to unpack that material once it's in the conscious is with a trained psychotherapist. And maybe the two could go hand in hand. And there is a study by, I think it could be Pressman. I think there's another one from the 90s that looked at talk therapy with CCB. But again, it was just like 12 participants. There was no peer review. It was just published on ProQuest. So the conclusions were very hard to support. But the fact that someone's been thinking about it for 30 years shows that there's probably some wisdom in there.
Yeah, beautiful. Thank you. And I just have one final question. You mentioned a couple of adverse consequences that came out of the study, and I know that the percentage was much lower even than in other cases, probably due to the sort of careful nature, the careful planning you put into this work. But I'm curious, like what types of screenings do you think might be helpful to ensure the safety of vulnerable participants? Like what might you do in the future, to make the screening more comprehensive? Is it even possible to have a comprehensive enough screening to ensure that these vulnerable participants maybe don't take part in the work? Would there be an hour-long intake appointment, or would there be more kind of psychological assessment measures, or do you have any sense or feelings about that?
Yeah, I do. Yeah. So we had nearly 300 applications for this study, and we had to turn away, 200 people for a variety of reasons, their medications, their history, their high blood pressure, their heart problems, their panic disorders, things like that. So yeah, we screened out a lot of people. Hence again why I was so worried about attrition, because I knew I had to be so strict to get it through the CIS Human Research Review Committee. I also think that that's a shame in some regards. Let's say, for example, someone with schizophrenia does CCB, and then for some reason they have an adverse reaction, and then we go, okay, well, we can't have anyone who has schizophrenia doing that. Maybe it wasn't to do with their schizophrenia. Maybe this person had an adverse reaction because of their heart issue. But then we go and say no one with schizophrenia can benefit from this treatment. That would be a bit of a shame. So that's why I think understanding the mechanisms of action is going to be really important, because then we can go, oh yeah, it really is doing trauma resolution. So yeah, when we have people with PTSD, we have to be really careful, because it's going to bring up their trauma, and for those people we have to be really certain that we have the support needed for them. So yeah, and then also there was that study. I mentioned it in the thesis, that there's a particular type of personality, a personality type, like people who can get into altered states of consciousness. I'm blanking on the name of the personality type, but basically those types of people, the type of people who often daydream, who often often very creative, often get into non-ordinary states of consciousness just naturally. They're actually the people who benefit most from CCB, according to, I think it was Hanratty who did that study. So identifying more about personality types, being like, let's say I'm thinking about some family members who have done CCB with me, and they're like, didn't do anything for me. Like they're very like in their head, very like analytical, very determined, and sort of type A personalities. Maybe for them CCB is never going to work, whereas for the more like the people I just mentioned, CCB is going to be better.
Fascinating. Yeah. Thank you, Richard. All right. Well, wonderful. I've rested my case. Let's move forward. I think I'll close it there. So Judy, if you want to invite our committee into a separate group, and then we'll give the rest of everyone else a chance to discuss.
Great. I will put you in now. Okay, great. Well, thanks so much. That was really, really amazing, Richard. And usually this is a point where I invite everyone who's here to, if you want to ask Richard anything, or have any comments, feedback, anything at all, the floor is open to do that. Yeah, go ahead, Nikki.
I was just wondering, how are you defining mystical experience?
Yeah, so in my paper, I define mystical experience in a variety of ways. So yeah, it's often like transpersonal phenomena. It's this sort of a broad thing, but it often includes some of those things I mentioned, like yeah, contact with ancestors, spirits, entities. It can be just a feeling of oneness, universal oneness. It can be a connection to a higher power. I think there is a sort of, I said it was non-ordinary states of consciousness, and I think within non-ordinary states of consciousness, mystical experience fits within non-ordinary states of consciousness. I think you can have a non-ordinary state of consciousness without having a mystical experience, but I think that what the importance of the mystical experience is that, like, that awe. I think we're starting to learn, or I'm starting to read more and more about the importance of awe in mental health. So often when people do psychedelics, they're just like, wow, wow, wow. And they say they've been depressed for a long, long time. And then they come back and they're like, wow, that was incredible. I feel alive. I feel like there is hope for me. I feel like I can change my situation. And their anxiety reduces, their depression reduces.
Rachel.
Hi, thank you. Thank you, Richard. That was really informative and wonderful. And forgive me if I missed this in the presentation, but I just wanted a little clarity on what the specific protocol was, how long each session lasted, and the cadence. And again, I'm sorry if I missed all this, but how many times a week and how long it all lasted?
Yeah, I did one slide, but it was quite a short one. But yeah, so it was once per week, people did a 90-minute workshop. For me, we had 3 workshop times available per week, so people could come, dependent on their schedule and their time zone. We would do about 10 to 15 minutes of introduction, explanation, Q&A, and we'd go for a little bit of like a body scan, a grounding meditation for a few minutes, and then it'd be 40 minutes, give or take a couple of minutes of the actual conscious connected breathing. Then we would do about 10 minutes of silence, music listening, and then we bring them back with a kind of grounding meditation where they connect with their body. Then at the end they would have another 10-15 minutes for Q&A, etc. And so yeah, that was 6 weeks of that, so 1 time per week.
Great, thank you.
Go ahead, Amanda.
Hi, brilliant piece of research, Richard. I've been following you, so yeah, really excited to hear you talk through it live. I'm just thinking about the way that psychedelics is going now in the integration piece, but there's also a piece around the preparedness, and I just wonder that is it personality type, or is it actually something around preparedness to go into a program of CCB so that you get people out of their heads, as you were saying, more into their body, so that then when they do enter a program, that you've already had them kind of familiar, and they're much more aware of their breath. I don't know what your thoughts are around that.
Yeah, I think it's a good conversation to have. Yeah, I often think about a sort of like a hierarchy of these types of things. At the top is iboga, then you got ayahuasca, then you got psilocybin, then you got MDMA, and then you got ketamine assisted therapies, and then I think breathwork comes just below that. Although I know some people have found breathwork experiences more impactful than ayahuasca and things like that. So that's just sort of on average. And then below that, I would say like a float tank, and then a sort of mindfulness meditation. So I often say to people, start with 10 minutes of mindfulness meditation, focusing on your breath, then try a float tank, then maybe you'll be ready for some more activating conscious connected breathing. But yeah, certainly some research to be like, what's the greatest harm reduction protocol? Maybe it's, people start with 6 weeks of meditation, then they go on to a conscious connected breathwork program.
Yeah, thank you.
I'm gonna, if it's okay, I'm gonna have Susanna go, and then we'll come back to you, Nikki, because Susanna hasn't gone yet. Go ahead, Susanna.
Okay, thank you. That was a really incredible presentation. I'm very new to this topic. I'm from a totally different department, women's spirituality. Could you super briefly outline the potential dangers of this practice?
Yeah, so we did a slide there on the adverse events we had. So the main one is tetany. That's the most common one, which is it's a type of cramping. So I'm doing this. This is what happens to people's hands. They cramp and they go into sort of like lobster claws, and then people's mouths cramp up like that as well. So it's to do with changes in blood chemistry. It's called respiratory alkalosis. So blood pH changes, and it happens when people are forcing their exhale. So if you heard Jim talk there about, we really got to focus on people having a passive exhale, because when some people, not everyone, no one really fully understands tetany and why it happens. When some people do the voluntary overbreathing with a overbreathing inhale and a forced exhale, they get this cramping, and it can be quite painful. It is just like cramp. So as soon as you stop doing that breath technique, it goes away. But for some people, sometimes this is the complaints you get about the breathwork industry. It's like, oh, there were 100 participants and just 2 facilitators, and I had tetany for an hour and I didn't know what was going on. No one was supporting me. So that's one of the dangers, the most common one. Every breathwork training school talks about that, but often students don't listen, and then they overcommit, and then they can't support enough people. The other one's emotional flooding. So this is where people get overwhelmed by their internal experience. So this is why like Bessel van der Kolk is now not recommending mindfulness meditation for people with PTSD, because their internal experience, it just becomes too overwhelming. And that's why people say that conscious connected breathing is actually better for people with trauma histories, because it's something active that people can do, whereas the passiveness of mindfulness meditation supposedly is too much for certain people. So that flooding can be something. So that's why we had the breakout room with my wife, Natalia. When we noticed people flooding in some regards, we would notice people maybe sitting up, looking around, just stop doing the breathing. We would check in with them and be like, is everything okay? And then we'd just be like, hey, I'm just going to send you into the breakout room with Natalia and you can talk about it. So that flooding is definitely one. The main one, the most severe one, was this depersonalization that this one participant happened in, and it's still ongoing 6 months later. So that's one that's really concerning. As I mentioned, 5% of people get long-term negative effects. People get depersonalization from many things, including Vipassana meditation retreats. Often people have psychotic episodes there. This wasn't a psychotic episode, but I'm just highlighting that even just mindfulness meditation can lead to lasting negative side effects for people. So that depersonalization one, I would say, is the one that deserves the most attention.
Thanks, Richard. And we'll take this last question from Nikki and then come back to the committee who's back. But go ahead, Nikki, with your question.
It was sort of a little tandem question. So, because I couldn't remember, did you say you didn't take people that took medications?
We excluded anyone who'd recently started medication.
So someone who's had an extended period, okay. I'm bipolar with PTSD and a generalized anxiety disorder. When I don't take my medications, I am bipolar enough that I hallucinate. So I take my medications. So I was wondering why you wouldn't take somebody with medications.
Yeah, because we wouldn't be able to tell if it was the medications changing people's anxiety levels or the breath work. That is not to do with safety. As I mentioned, so many studies have got so many confounding variables. We just wanted things to be really simple and really clear. So we said, if you started medication within the last year, we're not going to be able to tell whether, it's the CCB or the starting the medication. If you've been on medication for more than a year, we were accepting people. So it wasn't like we were telling people, you must stop your medication to be part of this study.
Thanks for clarifying that, Richard. And as I said, I see the committee is back, so I'm going to turn it over to Sarah once more. Thanks, Sarah.
Right. Well, we're back and we are delighted to announce that we are passing you with just some tiny little a couple little wording pieces, but you've passed. You can go out and celebrate. Big congratulations to you, Richard, and also thank you to Natalia for your help in this, and thank you to the committee members. Yes, congrats.
Thank you very much. Thank you, everyone. Thank you, everyone, for your questions. Thank you for the celebrations there, George. Yes. Thank you for the round of applause, everyone. Yeah, I really appreciate you all being here. Thank you.
Congratulations, Dr. Blake.
Thank you.
Yes, Dr. Blake. All right. Well, I don't know if there's any additional questions. I know we came back rather quickly because it was such an open and shut case. If there's anything else, we can take in another few moments. Otherwise, we can cut Richard loose and let him go, enjoy the day.
Yeah, Natalia's baked me a cake. It was either a celebratory cake or a consolation cake to make me feel better if I failed.
Oh, goodness. Wonderful.